the private. Without further ado, let's get into the discussion. So, I would like to introduce the panel this evening. Uh, we had such a fun time writing this report. Oh, I did work on the report as well. I'm one of the authors. So it's very exciting to launch this here with you guys this evening. I'm going to start with Luthando, furthest on the stage. Luthando is a lawyer whose work bridges the worlds of law, social justice, and sustainability. She obtained her LLB from the University of Cape Town, where she developed a strong interest in the legal frameworks governing natural resources and environmental protection. She went on to complete her articles with a particular focus on corporate mining and environmental law, gaining first-hand insight into the intersection of commercial imperatives, regulatory compliance, and environmental stewardship. At Open Secrets, Luthando's work tackles the ways in which corporate greed plays a significant role in state capture, international criminal conduct, and environmental harm. Then it's Zen Mathe, who's an investigator at Open Secrets. She contributes to investigative research across the organization's thematic areas. She has a keen interest in promoting justice, in holding perpetrators of corruption and economic crime accountable. Her investigative work has included focusing on private sector entities such as Bain and Company. She is passionate about sustainable development and climate justice. Zen has also worked in leading the organization's efforts in coordinating the civil society working group on state capture from 2019 to 2024. Zen holds a BA International Studies degree from Stellenbosch University and a postgraduate in Sustainable Development from the Sustainability University at Stellies. And on my right here is Fatima Hassan. She did ask me to cut her bio down, but I assure you she's extraordinary. She is a human rights lawyer and a social justice activist. She's the founder of the Health Justice Initiative. Among others, she is the recipient of the 2022 Calgary Peace Prize and the 2023 Echoing Green Fellow. She has dedicated her professional life to defending and promoting human rights in South Africa, especially in the health field. She holds a BA and an LLB from the University of Witwatersrand and an LLM from Duke University. She clerked at the Constitutional Court of South Africa, served as a ministerial advisor in 2 portfolios, and headed the Open Society Foundations in South Africa for 6 years. She's an honorary research associate at the University of Cape Town School of Public Health and Family Medicine. That's the cut down version. Yes, and as I've said, I'm Luvano Ntuli, and I'm really happy to have you here this evening. So we are going to start with a little icebreaker. And what I would like from you is wrong answers only, okay? So what we're doing, who owns South Africa? The private health edition. So can I get a show of hands for Kauai? Okay, okay. Those princess wraps aren't doing the things I can see. Herbalife. Vicks Vapor Rub. Yeah, yeah. And finally, run clubs. Yeah, yeah, yeah. We are all run club cult members here, actually. um, yeah, so I think run clubs won. They've taken over our algorithms everywhere we go. So get on it now. And you too will own the private healthcare system in South Africa. So yeah, I think we'd like to start this conversation just with a little bit of a kind of scene setting. So who in South Africa will be calling it WOSA here and there. So that's what that means. WOSA is an investigative series led by Open Secrets, and we're mainly looking at how private players own parts of South Africa's economy. And so this comes from, years of work, and we will roll this out over many more years. And, we wanted to focus on the private healthcare chapter, immediately after our launch of the system a month ago, to kind of focus on what's happening in South Africa's healthcare system. It's a mess. And I think we're really interested to kind of understand how, on one hand, there are so many debates dominating this, sector around the national health insurance. Um, just yesterday, the SIU released its interim report on corruption at Tembisa Hospital, and 2 billion has been looted by, various syndicates. And I think there's something to be said for what we know about the public healthcare system, and we know it's in crisis. And I think what we're really trying to do here is shed the light on the private players, your big names that are profiteering from healthcare. So that's Discovery, that's Mediclinic, that is Life, Netcare, Momentum, Bonitas. All of these different actors play a huge role in profiteering, and those are just the South African actors. There are a range of international actors that we're going to get into as well that speaks to the issue about financialization of healthcare. And so that's kind of where we locate today's discussion. And I'd like to turn to Zen, if you can kind of talk to us a little bit about the inequality that we see in the healthcare sector. Um, and if you can talk to us about the history, right, that shapes the sector and how we engage with that today. And how does the past inform the present? And how does that continue to shape access to healthcare in South Africa?
Yeah. Thanks, Luvano, and good evening to everybody. Um, for a little bit of a historical background, I think a lot of the work that we do at Open Secrets, but also generally, takes a long shadow look at at things, and so the context is really important because, especially when it comes also to South Africa's healthcare system, um, we see traces of the past, and that being a very big reason why we have so many of the issues we have. And I think just maybe not starting all the way from 16 colonial Dutch settlers. It's in the report, and you can have a read. But I think a little bit of a more recent history around the 1960s and 70s, you really see the apartheid government, you see the rise of private hospitals taking shape. But what you have is an apartheid government that protected um, the white people who had access to healthcare at the time. And so you have a rise of private hospitals kind of starting, but you have a state that's protecting, um, yeah, people from the exorbitant costs and regulations that try to ensure that people weren't exploited by rising white people at the time, so the minority, but weren't exploited by private healthcare that was rising. And that's excuse me, also when you have the first Medical Aid Scheme Act coming into power, coming into force, even though it was still protecting the minority. You have the beginning of efforts by the state to shield people from what was a global trend of rising private hospitals, particularly in the country. Then fast forward to the 1980s, and because of the political context at the time and the shift towards democracy and resistance that was happening, you all of a sudden have an apartheid government that's deregulating all efforts to protect citizens from private hospitals, and the proliferation of private hospitals begins to continue in the absence of regulation, and a widening class and a widening access is happening as a middle class, as a black middle class is also rising at the time. But in the absence of regulation, even though access was no longer was no longer racialized, the economic elements come into play. And in the 1990s, you have an ANC government that chose neoliberalism, but the private sector in the hospitals had already um, proliferated. So you have kind of an entrenching at the time of what we see today. And an inherited democratic state, you see, yeah, an inheritance of um, these private hospitals, and the access being replaced from socioeconomic um, issues. So yeah.
Oh, hello. Thank you. Yeah, I think that's comprehensive. It's hard to talk about apartheid era anything in such a short amount of time. And so you've kind of located us within the transitional period. And Luthando, I want you to pick up on that if you can, around our constitutional rights to healthcare. And if you can speak about the responsibilities of private actors as it relates to constitutional rights in healthcare. How has this played out in courts? What have the courts said about the responsibilities of private actors? And also, we want to talk about ownership patterns. Who owns South Africa? So if you can speak about all of this as it relates to the Constitution.
Yeah, sure. And thanks, Zen. It's very helpful to have that historical background because it helps us understand why the Constitution looks the way it does. It's a corrective piece of legislation primarily, right? It seeks to undo the injustices of the past. And Section 27, which deals with welfare and our rights to or our socioeconomic rights, healthcare, food, water, social security, is an attempt to do that. And it provides universal access. It says that everyone has the right to access healthcare. And that is something that, on the face of it seems like a great, excellent thing that we should all be able to access. It also underpins this value that as human beings, the right to have a life that is not plagued by illness and disease and death and fatality is something that we all have a right as part of, our sense of dignity. But of course, there's always going to be a countering responsibility, and that responsibility is primarily on the state. The state has a responsibility to progressively realize that right, which means that even though each of us has the right to access healthcare, that doesn't mean that the state has the responsibility to give effect to that in the most perfect way possible. And that makes sense, right? Because the state is limited by so many different factors, capacity, funding, purely just the massive task of having to give effect to that is huge. And our courts have recognized that in various ways, which is unfortunate, but it's also it's a reality that we have to accept. On the other hand, when it comes to the private sector now, and there's a lot of pushback from legal scholars right now around what are the obligations that we should be putting on private companies, considering how some of them have revenues that counter some GDPs of different countries. Like the corporate sector is a powerful, powerful actor right now in our world, and they only are becoming more powerful. But the law as it stands says that that obligation doesn't extend to private actors. So your discoveries and your momentums and whatever don't have an obligation constitutionally to provide you with access to healthcare. What they are required to do is to make sure that they're not limiting the right to access healthcare. And under the Constitution, they don't they aren't allowed to refuse emergency medical treatment, which is really important. It's also really why you'll see how security is so important at a private hospital, right? You got to make sure that the riffraff doesn't come in, because once you're in, they have to treat you if it's an emergency. In non-emergency situations, they have every right to refuse that, and that's something that we've seen the courts confirm. But as I said, there's this pushback coming from the academic sphere around how do we deal with horizontal obligations between natural persons and companies, because it is a deeply unequal relationship. And it's something where if you as a company are going to be fulfilling duties that are actually primarily within the state sphere, then maybe there should be some attaching obligations as well when it comes to how you give effect to that. And then maybe just kind of the last thing on like ownership. When it comes to medical schemes, like I think Zen kind of touched on this, they're actually technically not supposed to be for profit. Under the Act, they're supposed to be registered as not-for-profit schemes for the benefit of the scheme members. But we know that that's obviously not happening, and there are various different ways in which they can still make a profit on our sickness. It works for them if we're sick. Through administrative companies, through contractors, through middlemen, you know, the financialization you referenced and so on. But yeah, let me stop there.
Thanks,
I think
Luthando.
I answered your question.
Yeah, you did. You did. Thank you. Yeah, I think kind of this dynamic between private and public is really important. And I think, Fatima, you can kind of shed some light on this from your experience at the HJI, particularly around trying to access contracts related to vaccines between state and private companies. If you can tell us about your experience of that and trying, what lessons you learned regarding the relationship that exists between private and public actors as it relates to healthcare, and yeah, what kind of power the private sector really has.
Sorry. Thanks to Open Secrets for the invitation and the really fascinating report and work that they've done. I'd really urge you to read the report because I think um, the data and the information, particularly around ownership patterns, the shareholders, and the amount of money involved is so staggering that it puts, what happened yesterday into greater perspective. But I think as health activists and as people working in the health sphere, it's an important tool that we're going to have to use for the next 20, 30, 40 years, even when all of us are gone, to ensure that we have a more equal health system. Because I think the future of healthcare in this country is currently being written and being rewritten and being rewritten by the very people named in this report. So I don't want to be a downer, but I think you have to study this report if you are in this field. Study this report if you are a user of the healthcare system, whether you're in the public health system or private health system, it doesn't matter, because the future of our health is genuinely at stake, and we'll come to the NHI later. The second thing I just wanted to say is that all my remarks are prefaced on the basis that we view health and health products not as a luxury. It's very distinguishable from a piece of jewelry, from a car, which is a luxury. For us, it's a constitutional right, a right that we fought really hard to include in Section 27. And we've spent the better part of 30 years fighting legal cases to try and get enforceability of that protection, to ensure that progressive realization of the right to healthcare services can't be basically nice to have at some point by government that uses its budget as an excuse, or the lack of available providers. So we've really fought hard to push back against some of the more, I think, right-wing academics who are coming out and saying that, well, the government doesn't have an absolute obligation, nor does the private sector. We would say that cumulatively, with the Constitution, the Medical Schemes Act, the Competition Act, a whole range of laws, that PAJA, PAIA, a combination of laws, that we actually have quite a strong legal framework, and we need to use it as much as we can in the next few decades. The third thing I wanted to say is, yes, we have a corrupt, broken, dysfunctional public health system for the better part of it. It's not all that way. There's a difference between our public health system and our public health workers. And so we shouldn't conflate the two and put them into the same boat. And yes, South Africa has an inherited apartheid era inequality, and we have a two-tier unequal health system with disparities in the amount of resources for public and private. But having said that and having accepted that, we also have a private health sector problem and a private health access problem in our country, in our region, and globally. And so the way in which our private health sector operates, and I'll talk about the contracts case in South Africa, is very similar to the way in which it's operating globally. So there are few features of the private health sector in South Africa and globally. It's very expensive. It's actually inefficient. It overprescribes. It's extractionist, and it's hell-bent on profiteering. Now, the report doesn't deal with one of the major profiteers in this ecosystem, and that's the pharmaceutical companies. I know that Open Secrets will be dealing with that later. It's a much bigger, complex problem, but the pattern of behavior is similar. And this global health strategy, which is being propped up by the World Bank, which is being basically enabled by many governments in the global north as well as in the global south, is allowing private health actors to commodify what should be a basic human right, and that is health services. So we are treating health and health products and healthcare services as if it's a Gucci bag, security etc., etc., as if it's a piece of jewelry, so you can charge whatever you want with very little regulation and very little control. So I've tried to just give you a 100-year history in a short context, but that's how we got to the point of um, in a global pandemic during COVID, you'll remember that none of you could get out of your lockdown or travel the world or do anything or go back to work unless you are vaccinated. The only problem is that the companies that were making the vaccines were saying to the global south that you'll wait last in line, so very reminiscent to our own system of medical apartheid, and also you will agree to any of the terms and conditions we decide on, and we will charge you a price that you cannot disclose to the public. Now, the one advantage South Africa has with the public health system, and we spend billions in medical procurement on an annual basis, is that we have an open, transparent tendering system for public health goods. If you're buying a medicine in the private sector, we have transparency, limited, granted. It's called the single exit price. So basically, more or less, most of us know what we're paying for a product in the public health sector and the private health sector, but we may not know why. We may not know the assumptions underpinning that price. What we were told in COVID was that these four powerful vaccine manufacturers, now you must remember we're dealing with an industry, the private health sector and pharmaceutical industry, that's more powerful than the oil industry. Open Secrets has done work on the oil barons, on the oil industry. This is an industry that's more profitable and more powerful than even the oil industry. I'm not so sure now what they're going to do with Trump, but this is how it historically has been. And so this industry says to the South African government and many other governments in the global south, if you want the vaccines and you want your people to be vaccinated, you will sign a non-disclosure agreement. You will set up an indemnification fund within 72 hours, and you will agree to multiple terms and conditions, and you will also pay a price, which we later found out was inflated, and they were charging us even more than what the EU was charged. So something doesn't sit right when somebody tells us it's a secret. And there's an NDA when you're using public money, particularly billions of rands, and I'll try and wrap up here. So what the HAI did was said, well, sorry, actually, we're not living under apartheid. We're not living under an autocracy. At that time, it wasn't even a GNU, but we are living under constitutional democracy. There are provisions in the constitution around transparent public procurement. The only reason the South African government was put in the position where it had to negotiate directly with these companies, so this is unusual, because normally medical schemes and private providers will be procuring for their members and the state will be procuring for state patients, is that these vaccine manufacturers did not want to supply directly to any medical scheme or Solidarity or the DA or the Western Cape government. They insisted around the world that they would only have negotiations with governments because they needed the indemnification from different states and they wanted the price to be a so-called state secret. So that was the exception, but it's a precursor to what potentially could happen under NHI. And so you can read our analysis, you can read our report. We had to go to court. It took us 2.5 years. We use our access to information laws. Fortunately, the Gauteng High Court agreed with us that it's in the public interest to have a disclosure of the contracts. And if the companies wanted to stop the disclosure of the contract, then they should have come to court with their lawyers and tried to intervene in the case. But we argued this was a contract signed with our government, with these companies, with our money, not our duty to bring the companies into court. So this is a strategy for public interest lawyers to use going forward. And we said this was a backdoor way, basically, of opening the contracts. We were really after the contracts of Pfizer, Johnson & Johnson, AstraZeneca. This wasn't really about government's conduct. When we got the contracts and the negotiation records, it is alarming. The level of bullying, the level of demands that were made, the price inflation, the terms and conditions about whether we could donate excess supplies or not, where supplies would go to first. And by the way, we're talking about medical apartheid. Europe was prioritized over South Africa, even for vaccines that were made in the Eastern Cape. It was sent to Europe first because your lives matter less than people in Europe, according to global pharmaceutical corporations. So you can read the analysis. It's really, I think, worrying because this is now the trend of the private health industry demanding, because they were allowed to get away with it in COVID globally, demanding that governments in the global south now sign NDAs on all medical products, on all medicines going forward. And the issue, I think, going forward, and we'll talk about the NHI, is we're going to have a single procurement entity for the whole country, not just for 80% of people under NHI. And the question is, how will that unit that's supposed to be located in the Department of Health with its own issues going to withstand the excessive bullying of the global private health players, but also how will it withstand what's clear and a growing problem of corruption locally in South Africa when it comes to public tenders as well. Thanks.
Thanks, Fatima. I love how she told you guys that we're doing big farming like soon, and so now we have to do it because she's told an audience. No, but I think it's such an important conversation, and I think you kind of highlighted a really important aspect of what we're talking about here, and it's just the varying layers in which we're engaging with healthcare. And I don't know if she is here, but Kuliso from the Women's Legal Center, uh, they do a lot of work on sexual and reproductive healthcare rights. And I think that's such a critical part of the healthcare system that we need to engage with. So I'd like to invite her to give us a quick intervention on that.
Hi, everyone. I think it's been a very interesting conversation that's been happening, and we are constantly seeing the intersections and the growth in kind of the divide between the private and the public healthcare sector just thinning and thinning. I think within the context of this conversation, what's been very interesting in the last few years is we've been seeing a growing trend in the privatization of our public services. And we've been seeing a lot of contracts being concluded between the state and private entities to provide state services. And then there being kind of some friction in there at some point where because the state is not internally staffing themselves. So they will have a state duty to provide a service, but they're not actually training their own healthcare providers and healthcare workers. So they're not actually able to provide the service. So they contract out. But once those contracts have issues such as tax issues or compliance issues, then that contract is completely fallen the wayside, and hundreds of clients are now demanding services that they can no longer access because they've been contracted out and the state no longer has capacity to even provide those services. So we've gone into kind of a very interesting phase in the next, probably in the last few years and in the coming future, as to how the state is going to be navigating this whole system. Because on the one hand, the state itself is also quite struggling with providing state services. We are seeing, of course, increasing queues. There's a lot of frustrating processes and systems in place by the state. And they're really struggling with trying to get things to a very base level, from not only a lot of services being provided at tertiary levels that don't necessarily need to be provided at tertiary level, but having to decentralize that into secondary and private and more primary healthcare. And so they're struggling with a lot of those kind of bottleneck areas. And instead of kind of solving a lot of the internal problems that they've been having, they've been really relying on external service providers like civil society organizations or private healthcare institutions to build the gap. And so, in the context of really this conversation, I think on the one hand, there's definitely a need to better regulate the private healthcare industry, considering how much we are now moving our public services into it. And there needs to be a lot more better oversight into what quality private healthcare is being provided and what that looks like, and also a say from the public community as to what services should be outsourced, if any. And that's kind of a conversation that hasn't been had, and a lot of stakeholders haven't been engaged on the topic of which services that the state has decided that they no longer want to provide and would rather outsource, which is leading us to a lot of hot water issues where there's a very big question on a lot of services being halted. So, for instance, in the last also year, with the whole US aid thing coming to a crash, a lot of the state had been relying on external service providers like civil society organizations to provide healthcare services like HIV, SOGS services. And then once that funding crumbled, that state had to reabsorb a lot of that demand again, but they didn't have capacity to do so. And so, in the context of really this conversation, it's again kind of this revolving door where we're kind of going back and forth of passing the buck between we're going to provide it, then they provide it, and then we're not really going to provide it. And the only people who are really suffering at the end of the day are the women who can't access these services. Thanks.
Thank you, Kuliso. I think you've touched on an aspect that we want to talk to next, and I think all the panelists have as well, and that's around um, this issue around financialization and the commodification of healthcare, right? And what that means in real terms. And so it's something we spoke to uh, a lot in the system, and I think the system being the chapter before this, and it's something that comes up quite a lot within this conversation. So if you'll allow me just to talk about that for a second and kind of understanding what the consequences of financialization are on healthcare. And so, you know, what we argue, financialization being financial actors, financial motives on a kind of local and global level, shaping economic and social outcomes, both here and abroad. And so this increase in financialization, this increase in financial actors playing such a huge role in dictating, these social services is massive. And so what we see is that healthcare is no longer a social service. It's a commodity that is traded, it is sold, it's invested in by, you know, who knows who, which is what we talk about in the report. And so what financialization ultimately does is that it changes the fundamental mission of healthcare. It's about financial interests at the end of the day and shareholder returns. How much can you make BlackRock? How much can you make Vanguard? How much can you make Remgro? Et cetera, et cetera. And so what we see, this issue of financialization and shareholder returns, is that this rise in especially international investors, I think, is huge. And Fatima is probably going to speak to this a little bit later, but like you look at a company like Discovery, which is rapidly globalized since the early 2000s. They're in all the markets across the globe. And so, and as a result, they've attracted, these institutional investors like BlackRock, like Vanguard, who make hundreds of millions of rands. And then this money is then taken out of the country and it lines the pockets of these asset managers who have trillions of assets under management. And so there's a lot of secrecy around this. There's a lot of, you know, a decline in public accountability and ultimately higher costs as well, because we're paying them, for healthcare. And so I think that's been such an interesting kind of dynamic to look at in this report, is this commodification of healthcare and the lack of reinvestment. Patients continue to pay higher costs, wages remain low. And I think, such an interesting example of a shareholder that comes up repeatedly is Remgro. And Zen will speak on this in a moment. But I think Remgro took home over 122 million in dividend payouts from Discovery alone. It's also a major shareholder in Momentum. It owns Mediclinic. So this is the kind of thing that we're talking about these gigantic private players that have consolidated ownership within the sector and just continue to profiteer. And so, um, and I think just to go back to Discovery, because I think it's such an interesting case study to look at, is when it has so many, it plays on so many markets, it's a billion rand company. Adrian Gore is one of the wealthiest men in South Africa. And he's not on the dollar billionaire list yet, but he is working towards it. I can tell you that. And I think what we try to uncover is that relationship to political power that exists within the corporate space is really, really interesting. So Zen, I don't want to go on for too long, but if you can kind of speak to some of these individuals that we've highlighted in the report, where's the money? You know, who has the capital? Who has the power in the private hospitals, especially? And if you can, you know, Johan Rupert is on the cover of WOSA Health. He was on the cover of the system, and he will be there for many more chapters to come. So yeah, could you talk to us about some of those actors that you've seen?
Yeah. Thanks, Luvano. I'll just elaborate since you took me to Johan Rupert directly, directly there, and then the cost of that. And I think, as Luvano has mentioned, the issue of financialization and making health a commodity is that the issue of health is a matter of life and death, and so, and I think, as the panelists have said, Luthando, Luvano, and Fatima, this is, it's not a luxury. And I think there are so many issues in the healthcare sector and so many things to tackle and discuss, um, that when we were thinking about coming at this angle and looking at the reality that there is the private sector angle is sometimes not really necessarily left out, but isn't considered as a part of the important conversation because it's almost seen as if these are separate things. You know, there's the private hospitals and the public hospitals, and it's about access to one or the other, but they don't really inform each other. And that's absolutely not the truth. And when you have a lack of competition and a monopoly, which you have in this country with Mediclinic, Life, and Netcare, you take away not only consumer choice, but fairness and equality, even within those that are able to afford private healthcare, which in this country actually is not a lot of people. 3 out of 20 people in South Africa have medical aid, which means have access to private hospitals. And when you're thinking about that number, 3 out of 20 is shocking. Um, and of that 3 out of 20, 68% people are white people, and 10% of that are people of color. And so when we're talking about exclusion, at its best, we are talking about lack of competition and monopolization in South Africa's healthcare system. And when we're tracing ownership, I mean, beyond just that, the the competition commission found, and 6 years later we're still looking at this, inflation has, private hospital prices have increased at double the rate of inflation over the past 10 years. And so when we're talking about, yeah, the lack not only of the access for people who can't afford it, we're talking about people who are able to afford it becoming less and less and less over time, even those that are able to, which is part of the issue. I think the average standard cost of medical aid is around 2,000, 3,000 Rand. And when we're talking about um, more than half the country living beyond below minimum wage, not only do you have a middle class that's increasingly not able to afford this, you have the majority who are living under the poverty line, unable to afford it. Cross reference now to ownership. Johan Rupert, who is the primary owner of Remgro. And in the system chapter, we showed that not only is there such a huge disparity in wealth, the people, there's a 0.01% in this country that own majority of the wealth. And Johan Rupert is chief amongst those people. And when you have Remgro across the sector in private healthcare, you have, and you can see the rise in wealth, not only of Remgro, but of the individuals that own Remgro, and the lack of accessibility and the rise in price of healthcare. You we begin to understand and paint the picture of how these this sector is linked across the board. And when we are having a conversation just now about the NHI, and I know there's a lot to debate, in the historical uh, state, in the apartheid era, we saw that there were attempts by the state to regulate the private sector. And so when we're now fast forward, and that was necessary to protect people, even though it was the minority at the time. And so when we're having the debate, there's also a historical lens around that conversation. And now, yes, okay, you have your Henry Pitt, probably part of the pioneers saying no to the NHI, and we say no, but look historically, there was a minority of people that were protected from the rise of private healthcare, and now when we're having that kind of a conversation, I think it's important to also think about that in the lens and in the conversation. But just to end off, before I guess we can come back to some of this, um, for example, Mediclinic was a publicly listed company on the stock exchange. And recently, Remgro created a joint venture to be able to buy out the rest of the shares of Mediclinic and made it a private company and delisted it from the Johannesburg Stock Exchange. And now, not only do we have a further concentration of ownership, we have now another veil of secrecy because a non-listed company doesn't have to report its financials. And so we have more and more concentration that was flagged by the Competition Commission years ago that is not only not changing, it's getting worse. And on top of that, the the lens and the secrecy is growing in the nature of the way that the ownership pattern and the concentration is moving. And I guess we can come back to some of this conversation, but yeah, I think I'll just end off there.
Thanks, Anne. Yeah, I think that's the veil of secrecy is what we're trying to really lift, right? Is like, what does that actually mean and what does that look like in real terms? And you mentioned regulation, and that's huge. It's huge. Fatima, if you could speak to that a little bit, I know we're giving you all the hard questions. If you could talk to us a little bit about regulation of medical aids and hospitals within the state. Um, what are the gaps that exist within regulation? As Dennis mentioned, none of these regulation is getting worse, right? And so, what are the gaps to see greater accountability in the sector? And now let's bring in the NHI. Can the NHI, how does it fit into this discussion around regulation and the state and the responsibility of the state?
Okay, um, so I think let's assume for now there's not going to be an NHI. Let's just assume all the legal cases are won by big business because they are the ones litigating, and Solidarity and the DA. And I'm mentioning those because those are the usual litigants whenever there's an effort made by government to regulate medical schemes or the private sector business. So for those of you who remember, when we started out in 1994 under the Mandela administration, there was a series of acts and laws that were passed to try and remedy some of the past injustices and inequality in the health system, and then try and introduce some laws. And I don't know if some of you remember, but this really famous case of what was the first thing Mandela tried to do on medicine pricing, right? And medicine, for us who grew up in communities affected by apartheid, it's a trigger point because it was the difference between life and death around HIV, TB, cancer. We're just talking like, diarrhea, basic diseases. And we couldn't access those medicines because we were black or brown or we weren't considered white. And you couldn't even get it at a pharmacy because of the color of your skin. So the medical apartheid was real and it was alive. So one of the first things he tries to do is to ensure that South Africans going forward will have access to generic medicines, to be able for government to use measures, which are called compulsory measures to bring down the prices of medicines. And the first thing that happens in a democracy after everybody did the whole Mandela Rainbow Nation photo opportunity is that the US-based pharmaceutical industry sued the Mandela administration and the South African government. It's a very famous case called the PMA case. That's when TAC intervened and got them to withdraw. But ever since then, it's almost like there's been a secret deal. And we've been trying to uncover it for the last 30 years. Because after that effort, and the Medical Schemes Act and Tobacco Control Act and a few other pieces of law, it's almost as if government stalled any efforts to bring about laws that would actually benefit all of us, particularly people who have been historically disadvantaged, to get access to more affordable medical products, including medicines, to cater for FDI, to cater for the US trade minister and embassy. And we can talk about the Clinton administration, we can talk about other administrations before Trump even came into the White House. So over time, my view is that the regulation has been ineffective. It started out with like some gusto. We're going to have an equal health system. We're going to regulate the industry. We're going to bring the prices of medicines down. But it took a big knock when the PMA decided to sue the South African government. And it meant that a number of laws that we had been fighting for as health activists in the late 90s are still sitting in ANC ministers' desks. Now, I'm saying ANC ministers because those are the ones that have been given the portfolios that are most relevant for our work in this GNU. None of us think it's going to see the day of light ever because of the GNU. So if we're talking about regulation and reform and what government could have done, I think we're now in a very different context because of the GNU. You're sitting at the table with a party that has litigated against every effort to bring progressive reform on healthcare, the DA. You're sitting in the GNU with parties that do not want us to change our intellectual property laws that would allow us to bring the prices of medicines down. Why are you paying so much for your medical aid premium? Or why are you paying so much from your pocket when you go to a pharmacy to get your medicine? It's because we don't have proper intellectual property protections for patients. We have protections that protect corporations because we're treating a medicine for HIV or TB or cancer or cystic fibrosis as if it's a Gucci bag. And that's the reality of what's happening. So even within schemes, we tried to get as much laws passed around the Medical Schemes Act that it shouldn't have insurance risk rating principles, that all of you can join a medical scheme. Nobody can deny your cover, but you may have to wait. You may be excluded for cover. You may have a pre-existing illness waiting period. You have hundreds of plans that you can now choose from. Choose is a loaded word because you actually don't have choice. It depends on how much money you earn or whether a family member can pay your premium. We have numbers of patients losing membership because they've lost their job. Often medical scheme membership in South Africa is tied to your employment status. We have a massive unemployment crisis in one of the most unequal countries in the world, but we want people to pay a medical scheme premium that is so high, and then on top of that pay a co-payment, and then on top of that take money from your savings account, all and I really don't mean this flippantly, like really all to benefit a handful of shareholders, and it's not millions, it's actually billions, the numbers are in the report, that they're making in profit annually. Those billions surpass the 8 billion that we just lost from the US government in terms of the US funding for HIV and AIDS. So if you put things in perspective, the amount of profit that is being made for shareholders in South Africa and outside South Africa is quite staggering. And for me, what was quite alarming in the report, and it's giving us a new tool around how we're going to regulate, how we have shareholder responsibility, how we hold these companies accountable. Aside from Adrian Gore and Johan Rupert and all of the money they're making as individual shareholders and Remcro and BlackRock and companies that are on the international BDS list, those companies shouldn't be even investing in our country. I mean, we've got a case at the ICJ, right? But guess who's in almost every page when you look at the shareholding for the big six? And the big six are Discovery Bonitas Momentum. Some of us are members of those. Lifecare, Medicare, Netcare. Some of us have been to those hospitals and clinics. It's the PIC. It's the IDC. So for those of you who don't know, the Public Investment Corporation, it's our money. The IDC, that's kind of our money too. And the Government Employee Pension Fund, that's our money. So when you talk about regulation and why there hasn't been the speed and the haste of ANC government ministers for the last 25 or so years before the GNU, one must ask, did it have anything to do with the fact that all of these shareholders, which is government, which is the state, didn't want to rock the boat, not just for political reasons, but also for financial reasons? Because they are, in some cases, even a greater shareholder than Remgro or Adrian Gore. I mean, it's quite bizarre to have an individual. We are naming him and we need to shame him because he has a lot of money and he's made this off the back of Discovery Medical Scheme, which, if I can just explain to people why we have an issue with the schemes like Discovery and others, when you are a not-for-profit medical scheme making excessive amounts of profit, is one, you are named in reports around racism in the private health sector field, where black doctors and brown doctors are not being given entry options into these spaces. I'm simplifying it. You can read the report from the Council for Medical Schemes. Number two, there's billions of unpaid, rejected, denied claims. So these are medical scheme members of the main medical schemes, particularly Discovery, you, me, your grandmother, your father, your sister, paying diligently your medical scheme membership, and then you claim and you don't get reimbursed and your claim is denied, rejected. I'm sure you've all seen those letters. That's not a negligible amount of money. That's a considerable amount of money every year that South Africans are not being paid. And I think the third thing, which is why it's so galling, is within these schemes, privilege is existing again as a proxy for access. We've just been trying to work and help the South African cystic fibrosis community, just as an example. Within Discovery membership, so you would think person is fine, they sorted, they've got their Discovery medical membership. No, if you're on a different plan, depending when you joined, how much your contribution is, you're just excluded from cover. Literally, right now, there are men and women and children who are getting more sick, who are literally dying because they can't access a life-saving drug because Discovery rejected them or Discovery denied them or Momentum said we don't cover this or Bonita said no way, your membership is so low, the premium is so low, no, you can't qualify for this higher end treatment. So I think what I want to stress is that our government has been remiss, and here I blame the ANC government because they had the opportunity, they had the time, they also could have done this in COVID. Everything that they were scared of has happened with Trump. All the trade pressures, all the tariff threats, everything that the US administration had always threatened South Africa with for the last 25 years, if we change the law, if we regulated more, has actually all materialized. But now the government's paralyzed because we have a GNU and none of these reforms are going to happen. And then I really just have to end off by saying this. We have had an intellectual property system in this country that is an apartheid era relic, and it hasn't changed for 30 years. If you have any access to any government policy maker, you need to tell them that this is unacceptable. We have a system that is even in excess of what global intellectual property rules require, and that is why you are paying more for health products. But our government has had a law drafted, written, for the last 7 or 8 years. It's been approved by cabinet, and they refuse to pass it. So, I can sit here and talk about we need to do this, we need to regulate that, we need to follow this judgment, but our government has the power. In many cases, they quite a considerable, significant shareholder in all of these health companies. They need to act and they need to pass the law. And if the DA is serious about protecting people and protecting their choice, and this is the arguments they make in their legal papers in the vaccine case or in the case of the NHI, then one must ask them too, if you are DA voters, why are you blocking reforms that could bring down the price of health products or any other political party that you may support or may not support? I don't know.
Thanks, Fatima. Yo, she clocked them. She ate them all up. Yo. Yeah, so I think, Luthando, if I can turn to you. I mean, Fatima's just spoken to, the DA and kind of the debate around the NHI. And, you know, what are we seeing around, the voices that are in the ring right now around the NHI? Um, there are, private, public, all of that. So what are the private healthcare firms and the industry groups saying in these legal court cases that they're, throwing at the state? And what is the significance of these cases? And yeah, can you talk to us a little bit about the nature of these actors as well? Because like Fatima said, it's not about you and I.
No, Fatima has got my blood boiling. I'm literally thinking about how I have had to pay for my own medical aid services this entire year out of pocket, despite paying premiums, because I was hospitalized at the beginning of the year. It's September. Anyways. So yeah, as Fatima mentioned, it's the usual suspects who are bringing cases to make sure that the NHI doesn't see the light of day. And I can understand why you're pessimistic on the chances of it ever actually being implemented, because the dissenting voices coming from the private sector are powerful. They have an exorbitant amount of money to spend on legal cases and court fees, which again speaks to another aspect of our society that allows for the powerful to profit and to protect their rights at the expense of everyone else, our judicial system, our court system. And we're seeing solidarity, we're seeing DA, we're seeing representative bodies and associations of medical professionals, medical scheme funders. There's also not entirely consensus within the ANC around the NHI. There were dissenting voices amongst different party members there as well. And it makes sense that these actors would be the ones to bring these cases, right? They want to ensure that they are able to make profit no matter the cost. And if the NHI does actually see the light of day and does come into effect, if it's successful and achieves its mission, it would essentially render the need for private healthcare irrelevant. We wouldn't have to pay for private medical services because our state would be able to provide those services for us at an affordable rate with dignity and care. And that is the worst possible thing that could happen to Discovery. That's the worst possible thing that could. Got dignity? Oh, no, 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 no. We can't have that. And I don't know, I guess I just have to laugh about it because it's really scary, right? The arguments that they're bringing around this are on a constitutional basis. They're saying that because you'll have to use the NHI and no longer be able to choose private services, you are limiting the average person's choice to quality healthcare. That is the limitation on Section 27. It's ridiculous, right? But there are some legitimate concerns, unfortunately. And I think it also probably is the reason why, it speaks to this issue that you're touching on, Fatima, about why did the ANC, why did the state not make further improvements around access when it had the power to do so? Because we have a corrupt healthcare system, as we've mentioned several times already about this SIU report. Unfortunately, looting is happening left, right, and center, right? If the state now is tasked with this even more burdensome responsibility of providing somewhat universal healthcare through the NHI, how are we going to ensure that procurement processes are done in a way that is transparent, that is done in a way where costing is negotiated fairly, that is done in a way that does not allow for the hospital clerk to get a 2 million Coke, it's really crazy stuff out here. And those concerns are ones that the state is going to have to answer now in these court cases. But we also have to ask the question, why were these things also not considered? Why were they not built into the legislation? Why were they not built into the policy and the implementation? Why didn't they try their best to do it right so that we wouldn't have these challenges from racist institutions and racist healthcare service providers? Another issue that they're bringing, or at least from the perspective of the Western Cape government, read the DA, is that there was a public participation issue. And essentially that the people of the Western Cape's concerns around the NHI were not taken into account when the legislation was finally signed by President Ramaphosa. That's crazy. um, so yeah, and then there's another issue also around funding, right? That's going to be the biggest one, the financial aspect of everything. And the problem with this issue is that different voices, no one agrees on how much implementation is going to cost. Forget where the funding is going to come from, whether it's going to be coming from taxes, where it's going to be coming from the national fiscus, all these different potential sources of income that also come with their own issues around transparency and public finance procurement issues. The private companies are saying that it could cost excess of R1 trillion. But that amount is based off of what they are charging the average user for medical services. And as we've already touched on, that is an exorbitant amount of money that is not reflective of what it actually costs to provide quality healthcare. That's what it costs for them to make money. So yeah, there's so much more I want to say on this, but yeah, Abby said no.
Timekeeper Abby.
Timekeeper Abby said no.
No, I think we'll definitely get a chance to come back to this. Get your questions ready. We're heading to a Q&A soon. But before we do that, Fatima, what are we gonna do? What are we gonna do? What, given all of this that we've just talked about, what does the state need to do to get the NHI right?
Yeah. So, okay, first, so I'm going to answer this in two parts, right? The first is that there are concerns with the NHI Act, which the president has assented to, but it's not yet in effect. You've touched on some of the major sticking points, which everybody will agree to, except for the Minister of Health, who's a very vociferous defender of the NHI. And unfortunately, in my view, is also very xenophobic. He's the wrong minister. And yesterday he made one of the most outrageous and inappropriate statements about uh, why don't we have a system, I'm paraphrasing him, this is not my quote, why don't we have a system like they have in China where you execute people who are guilty of corruption or you think are guilty of corruption. When the SIU report came out about the 2 billion looting that happened at Tembisa, which Babita Deokan was assassinated for exposing as a whistleblower. So not appropriate, because we've outlawed the death penalty in our country and we have a constitution. That's not what the health minister should be saying. So unfortunately, a lot of the criticism about the NHI is being conflated with our anger at how the minister behaves and what he says. And so I'm going to try and sift through the personality part of it and take you through some of the issues. So definitely issues around the scale of public corruption with public procurement processes, even if you are procuring from a private supplier, that's an obvious. Issues around transparency. We don't think the drafting of the many, many committees that they've decided to set up through this NHI are going to be robustly transparent. Even simple things like, will the minutes of those meetings be made public, like in other jurisdictions? We don't even have that provision in the Act. Issues around conflicts of interest. Who are you putting on the committee to decide what services all of us will get, at what price, what services will be excluded, what services will be included. The COI's conflicts of interest are not properly dealt with. Composition of these committees, who will be making decisions for all of us. And by all of us, I mean all of us with the South African ID document, because the other issue in the Act is they've just got a whole lot of exclusions. They've created, the Minister of Home Affairs became the Minister of Health. Before that, he was the Minister of Health. If you read that Act, it's like health and home affairs are going to become one. And if you've seen the attacks and the xenophobic violence that has happened in the last few weeks, despite what our constitution says about emergency medical treatment and free treatment for children and pregnant women, children under 6, where foreign nationals have been turned away. In one case in Hillbrow, I think Health EO Groundup has reported that that resulted in the death of a child being turned away from health services in Gauteng because of Operation Dudula's very violent, very xenophobic way in which it is actually patrolling the entrance to clinics and hospitals in Gauteng. So the minister has said that people who are opposed to NHI want apartheid back, or I'm paraphrasing, don't understand the issue, haven't read the act, want their privilege, etc., etc. So part of what he says is true, and I think a lot of what he says we don't agree with, because in our view as the AJI, and you can read our analysis, excuse me, paper on our website, it is badly drafted. So yes, they had public participation, over I think 200,000 submissions. I don't know how that public participation argument is going to pan out. It was an extensive consultation process. The problem is that they didn't listen to anybody, and even the Bill A to the Bill B to the final act hardly had any tweaks. Normally you go through a process like that. There's a lot of revisions. We've worked on many laws before and changing it, before it was assented to. This is unusual. Nothing was taken into account, maybe one small thing. So exclusions, the act is, I think, very xenophobic, very limiting. It's going to make you go, even as a South African, and show your ID document. Many South Africans don't even have an ID document. So it's just going to become a bureaucratic nightmare, let alone getting into the door and then getting your service. The biggest problem for us is it's so confusing that we don't, as Health Justice Initiative, our focus is on access to medicines. Greatest issue for us is this act, far from doing what it said it was going to do, which was to unify South Africa's health system and have one system and fair and dignity and everybody gets the NHI benefit. It's created 4 medicine access systems in parallel to each other. We don't know how this is going to work. We don't know which system you will have to use. And we don't know for how long and what regulation there will be for the 4 different systems. At the moment, we have 2 medicine access systems, private and public. They've just created 4 because of all of these xenophobic exclusions as well, right? The most important thing about the NHI Act, which is why it's so interesting that there's 8 legal cases from, we believe, institutions and organizations that are using the bad drafting to entrench a situation of privilege, to extend the status quo using the choice language. When you tell somebody, oh, you're taking away my choice, people immediately start believing you, oh, this act must take away your choice. It actually doesn't do that. So the thing about the public hype and some of the, I think, incorrect media reporting and some of the fears and anxieties is that people have not actually read the act. And this is why it's so bizarre that all of this litigation is happening, because the act clearly says, contrary to what the minister says, are we going to have an equal health system and NHI and socialized healthcare, it actually allows medical schemes to operate for the unforeseeable future. And I can quote the exact provision. For it will continue until a date to be determined by the minister when he feels or views the country as having a fully implemented NHI. That's never going to happen. No, I mean, in all seriousness, it is impossible to get to a day, whatever, in the next 20 or 30 years where you can confidently say the NHI has now been fully implemented. The rest of the 16% of the people on medical schemes can now come into the public health service under NHI. And when he makes that determination, what's going to happen? 16 lawsuits will be brought to challenge his determination, and then that will be extended. So for me, and I am on a medical scheme, and I understand my middle class family's anxieties about NHI and everybody else's anxieties, this is not the issue to worry about. Your medical scheme is going to continue. On top of that, and I think here comes the rub when we talk about ownership and what's going to happen to this market, this is a gift to the private health sector. Because unlike the Medical Schemes Act and what was promised in 1994 around social solidarity, no risk rating, removing insurance principles from the way medical schemes operate, guess what the Act does? Firstly, it uses insurance in the Act's name, National Health Insurance. So that's the first sign of what's going to happen. The second is the Act says that, contrary to what people are arguing about their choice, if the NHI cannot give you what you really want, the top-end medical service, Maybe you go to a fancy gynae, I don't know, maybe you go to a fancy asthma doctor, you want the best cancer treatment, not the cheaper cancer treatment, you want an oral tablet, you don't want an injection of the same medicine, and the NHI does not include it in its benefits. There'll be a package of benefits, right? A basket of services. If the NHI will not or can't because of affordability, and obviously government can't provide every single treatment that's available in the world, then you can buy what's called top-up insurance. And so now all of a sudden, we're going to have top-up health insurance companies and products that are going to fill the gap. So you will pay your NHI contribution fund, whatever, if you're earning, and then you can take out top-up insurance and get all the fancy things you're already getting. The third thing about the NHI Act is currently if you're using Dr. X here in the CBD and you're not going to Somerset Hospital, you'll be able to continue using Dr. X to get your services that's under the NHI if he's accredited under the NHI and the state will pay him directly. It's called the reimbursement model, which is why you need the funding. So I'm trying to explain it as simply as possible, and we've been saying we don't understand the legal outrage and the anger because the act is actually, in my view, very regressive. It's allowing this thing, it doesn't have a sunset clause. You're allowing, I'm going to be dead before the NHI comes into effect, to be honest. Like, you just don't see it happening. So I think what's really happening, this is my own view, and you can all disagree, but this is a power play. This is a power play for market share. So if you hear what Richard Friedland, the CEO of Netcare, is mentioned in the report under Netcare, one of the largest hospital groups, said at a medical hospital conference a few months ago, last year, he said, well, the problem with the NHI, blah, 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 we need to make it compulsory for every person with a job to join a medical scheme right now. And you're like, how does that make sense if you're going to phase out medical schemes, right? You have Discovery saying, we're not against the NHI. Oh no, we believe in social adjustment, social justice. We're part of government's delegation. We're part of business leadership. We really support this rainbow nation. We just have issues with the way it's drafted and what is the future role of medical schemes. And then you have the president saying, as if he's the all-powerful in this GNU system, outside of parliament, that, okay, fine, he's heard businesses' concerns and he's going to edit the act. The constitution does not allow the presidency to be parliament. Parliament is parliament. You want to change the act, you're going to have to do it through a parliamentary process. Whether we agree with the president or not is, you can't run shortcuts around processes that we've worked really hard to establish. So I think it's very concerning. I don't know what's going to happen, but I think there's going to be a settlement agreement of some sort. But yeah, I don't see NHI being implemented even, in small parts in the next years. But the Department of Health thinks it is, and they've already started their NHI pilot projects. So unfortunately, what's going to happen is a bunch of judges and lawyers, and I'm a lawyer myself, so I can say this, are going to decide what the future of our health system and health services are going to be.
Maybe she was the wrong person to ask that. I jest. Thanks, Fatima. So we're going to open the floor now for a couple of questions. But before that, we'd asked Section 27 to join us this evening, but they couldn't, unfortunately. But they did send us a statement which we want to read on this issue. They've done a lot of work on social justice and health rights, and I think it's critical that we have their input before we open up to the floor. So I'm going to ask Raisa or Mike to read out the statement for us quickly.
I think I'll just stand where everybody can see me. Can everybody hear me? Okay, cool. So yeah, like Luvano said, this is just a short statement that Section 27 sent to us. As a public interest law center, we are often at the forefront of health access cases which expose some of the underlying issues that are responsible for the deterioration of our healthcare system. While lack of access can be attributed to systemic challenges such as limited resources or persisting historical inequalities, the major catalyst that drives and perpetuates these challenges is the rampant corruption that has been allowed to ravage the healthcare system unabated for years, and the lack of political will. We see the impact of these two catalysts in our work every day. Whew, sorry. I think the heat is getting to me a bit. Um, I'll just take a minute. No, I'm okay. We see the impact of these two catalysts in our work every day, whether it's the death of the 141 mental health users in the Life Esidimeni tragedy and their grieving families. Okay, sorry, Jane. Go ahead. Sorry, guys.
Hi, sorry. I'll finish the statement. Sorry, wait. My eyes aren't fantastic, so give me a second. Thank you. So we see the impact of these two catalysts in our work every day, whether it's the death of the 141 mental health users in the Life Esidimeni tragedy and their grieving families that we represented, families who till today have not received the justice due to them, or the 3,000 cancer patients awaiting radiation oncology services and who continue to wait despite a special allocation of over 700 million rand for the provision of time-sensitive treatments. We have seen that those who stand up against corruption at the Department of Health often do so at the risk to their lives, and like the late Babita Dukoran, are hunted and killed for being true custodians of the right to healthcare in our constitution. Our healthcare system is under siege, and if we relinquish it now, if we relax at this pivotal moment, we risk losing it and the 85% of South Africans who rely on it. Thanks.
Thanks very much. Thanks, Jane. Thanks, Raisa. So I think we'll open up to the floor. I think that was quite powerful, and it reminds me of one of the speakers from the system said that when the state is under attack, we have to defend it. And I think that is probably what we're trying to do our best at right now. So there are a couple of questions from the live stream already coming in. So if you have a question, please raise your hand and I'll take 3 at a time. One in the pink. Also there, Abby, in that row, and then one up here.
Thank you for the very interesting panel. I'm wondering if there is a lot of like global influence coming in from, for instance, America, in the same way that they try and influence African countries in the way, like they often come and influence LGBT rights, for instance, in African countries. So I'm wondering if they are trying to influence rights to healthcare in various ways, whether it's like abortion or that kind of thing. Do we see that happening?
Hi, thank you so much, panel, for all your insights. My question is about maybe the tactic that all of these, like the momentums and discoveries use to approach government and to procure these kinds of contracts. Are they trailblazers? Are they using kind of established routes to be able to approach government to say, we'd like to privatize this existing hospital, or we'd like to make this contract? Yeah, I guess I'm interested. I haven't read the report yet, but yeah, there's like those kinds of understandings of if discovery is really cool with DA, but not so much with ANC, and how it works across those kinds of channels of comms. Yeah.
Thanks for those. And there's one more.
Evening, everyone. Thank you very much, panel. I would like firstly to say sorry, I kind of rolled in late, so I might have missed this, but I wanted to direct a question to Fatima, particularly concerning the history of our country post 94, right? I want to find out, are there key turning points or like monumental times when the state could have done things differently to prevent this dire state we are in right now? Because, and I carefully define dire when I say that we have a dual system for starters, and in the private health sector, we're talking about 6 people holding a monopoly over everything. What could government have done differently?
Thank you. Thank you for those. Panel? Uh,
I have
Zen?
a suggestion.
Cool.
I want to take the question I want.
You wanna?
The first question,
Cool.
and then
Zen and then Fatima.
yeah.
Great. Thank you.
Because I think it's yeah. Thanks for that question because I think it's something that speaks to how this conversation is obviously happening within the context of so many different global political issues, right? So I'm not entirely sure about specifically to your point about the US, right? I mean, we know there was obviously this whole era of tariffs and Trump and Johan Rupert and Cyril going to have tea in the White House and all of that. Um, and because those things are happening, they want to make it seem like it's happening openly, but we don't really know what those conversations are leading to. We don't really understand like what the end result is going to be from that. But we do know that there's always going to be this relationship that our government has with global financial institutions, right? Your World Banks, your IMFs, your what's it called, Basel, and those institutions are operating under the political will of your powerful Western superpowers, right? And when they are entering into these agreements and loans with our government or any other global South country, they're doing so with preset conditions. And those conditions are extremely difficult to be able to combat if we want to be able to get, get the funds. And they say, to varying degrees, that they're trying to shift to a more egalitarian approach towards this because, of course, we know how the financial institutions have played a role in keeping Africa in a state of poverty, keeping Africa in a state of indebtedness, creating this idea that we are unreliable creditors. Unreliable debtors, despite the fact that even in the case of healthcare, we pay more than anyone else because of this. So actually, we're more likely to pay back loans than anyone else, right? And then the other thing I wanted to say when it came specifically to your point about LGBTQ rights and access to healthcare, in this country, there are people who are actively fighting against abortion rights. In this country, we have people who are fighting against access to healthcare for queer persons and for LGBTQI persons. And that's the conversation I think that we should be having. There are so many different organizations like the Triangle Project, like Sweat, who do such amazing work around this. And we should be giving our support to them because they're the ones who are fighting, on the behalf of some of the most vulnerable people in our society. Yeah.
Yeah. I have strict instructions from our host, Luvano, to keep things short. Um, yeah, yeah, good luck. But following on from what Luthando, and I will be very short, is the question around the global influence. I mean, if we look at the mapping of ownership that we've done, and there's a diagram that we've drawn up to really try and visualize this complex web that we have tried so hard to tease out in this report. There's 7 international companies that have stakes and ownership across our healthcare system. And so when we're talking about global influence and the amount of shares that they are also getting, it's huge. And if you are driving, which private companies do, to please the shareholders and to deliver dividends, and to commodify that, of course, who your shareholders are will have influence. And when we're talking about those international companies, not only are they getting the money, and the money is now being siphoned out, the influence of who they are and the decisions that they're making around that are also important, and that's how influence also comes. And just on the last point, in the effort to be short, and I think Fatima will speak more to this, and I think Luthando has as well, and Luvano will add anything. Did the state have a chance? I think this is why it is so important to trace the context and the history, because yes, it's the simple answer. Not only did it have one chance, and if anything, I think Fatima has driven home the point that it's maybe too late. I mean, we don't want to be alarmist and pessimistic, because here we're fighting the fight, but we're fighting the fight. But yes, the state had multiple opportunities, and yes, maybe if it wasn't at the turn of democracy, right? In the 30 years that followed that, there were ample opportunities. And if anything, the neoliberal stance that the ANC took at the democratic transition, yes, was globally influenced, etc., but it prioritized corporations, and that's what choosing neoliberal policies over, even though you have a constitution that is progressive, you have healthcare being um, put in the Freedom Charter in the 1950s. There was this lead up where now you have this chance and you miss it and you fumble the bag for 30 years after that, at the cost of not only the people, at the cost of not only fulfilling what you said in the UDF 1950 Freedom Charter, now the Constitution, you choosing corporate power, not only now at the cost of the people, but also at the enrichment. The ANC didn't even have to be that creative. They could have just done, they could have learned from the apartheid government, because in the 1960s and 70s, the state did protect with regulations, corporate power and abuse. And so even if you didn't get that creative, you could have just kind of borrowed some principles, if that's an unpopular opinion. But I mean, yeah, I think, did it have a chance? Yes. Cut it.
Fatima, before you come in there, I want to throw one more question at you that came from the live stream that I know Abby's like staring us, but I think it's important. And it's around Tembelihle from online said, I'm joining as a patient with a rare disease and a disability as a result of that disease. I'm interested in how rare diseases fit into all of this and what the future looks like for the growing number of persons living with rare diseases who are reliant on private healthcare but are not surviving the cost of rare disease and poor health systems in private and public. And I think you mentioned cystic fibrosis, but there are many other rare diseases. So I just wanted to throw that to you to also try and answer that as well.
Okay, I'm going to try very quickly. The one is the US evangelical impact globally in other African countries and South Africa, as well as the Trump administration's impact of the funding cuts, does mean a cut in services for trans people, sex workers, LGBTI population. So those clinics have all but disappeared, not just in the Western Cape, but in other parts of the country as well. And now NGOs again have to step up because our minister is concerned with young women and children, but is not mentioning what we call these vulnerable populations and groups. So you can't really change our policy because we have it constitutionally protected, but the problem is in implementation, who's going to fund those specialized clinics and services? And that's why the 8 billion that we lost from the Trump funding cuts for all countries, not just South Africa, is so critical. That's why we're worried about what's going to be in the package of services for the NHI, because we don't really see the talk and the walk of the minister as somebody who's really concerned about vulnerable populations. Having said that, there's a separate parallel attempt to influence governments around the world, including trying to change some of the de facto work that we do in our country. And that's through a very well-funded, very well set up evangelical right-wing network that is based in the US even before the Trump. Poncho Polane has written an excellent book about that. I'd urge you all to read that to understand how sinister it is. So it's not just corporate power that we're trying to push back against, we're also trying to push back against religious dogma and religious power. And it's having a dramatic impact, especially countries in Africa where it's not even legal to be gay. It's, you know, there's no attempt to even regulate or legalize sex work. You can't even be openly trans or get gender affirming care. All of those services that we've had in our country trying to do that over the last few decades are now in parallel. And that is something that we've been fighting with the Minister of Health about. Is like, where are you going to find the funding? What's the plan here? How are you going to continue services? Because you can't stop services. That's the one good thing because of our constitution. So that's just a side note. Discovery and the contracts and the PPPs, we're still not at that stage, but I think that's the point of the future of civil society and the media, is the vigilance around what's going to happen under NHI, because we put a glimpse of how this private health sector and business operate in the COVID pandemic through what was called the Solidarity Fund, and then a number of other contracts where PPPs, public-private partnerships, are used as this, you know, soft way of trying to access control and power by offering services that the state can't provide. And obviously it works in South Africa because our public health system is under siege. We provide, you know, people do their own education, people do their own security. It's become so normal to pay taxes, but then also access services privately, because you just can't rely on a sustainable supply of power or sustainable supply of, you know, proper security, especially in informal settlements and in areas where there's high levels of violence. So this is a question that I do like and want to answer about what we could have done differently. Everything, right? So in 1994, we shouldn't have allowed, in my view, medical schemes to continue, because now it's too late to cut back. We should have introduced an NHS system similar to the UK and many other countries, where we immediately dealt with the inequality in healthcare and education. We've allowed privilege and excessive amounts of power and excessive inequality to grow, and it's just very difficult to put everything back into the box now and to regulate. So I think 1994 was the first point where they could have changed things, but this was a concession to FDI, to big business, to US trade pressure, and many others, that medical schemes would not be taken away, private education schools would not be taken away. It was really a concession to how do you make big business still operate and get a small piece of the market, but a very profitable piece of the market. The second one was when Mandela settled and agreed to settle the PMA case. We should have fought back. We should have seen the settlement agreement, and we should have pushed back on excessive pharmaceutical power. I promise you by now you'd all be paying lower prices for medicines. Other countries have done it. And when our government, to its credit, the ANC government, tried to introduce laws to benchmark, so we are paying the prices of Australia and other OECD countries. I don't even know why we're a middle income country, given our inequality status. So we're paying prices comparable to European countries and Australia. When we try to introduce, or when government tried to introduce laws for benchmarking, which is a perfectly permissible tool, big business stepped in, pharmaceutical companies stepped in, litigated, brought all their lawyers from Centon, and every time government has tried to introduce benchmarking, this has been resisted by big business. Didn't deal with corruption early on, or properly, didn't fire people who were corrupt, didn't fire MECs, didn't fire ministers. Very slow in regulation, haven't passed the IP laws. We could have done it 8 years ago, could have done it in COVID, didn't. But that doesn't mean the state can't do anything now. And I think that now there's actually more potential for us to hold those in power to account, because the GNU is not just the ANC. It's all those other parties, and we have to hold them to account, because whether they like it or not, they're making decisions as a government. They are the state. So it's very weird that a party in the state, in the GNU, is suing on the NHI, because they haven't figured out at cabinet level what exactly is their GNU policy on this. Do you want me to do rare diseases or not? So I think this is the big issue, because the concern around rare diseases, and the person online should contact the Rare Disease Network, we can give them the information afterwards, is that there's nobody to fight for patients with rare diseases. It can't be that patients themselves in a few small NGOs have to fight for inclusion of benefits and services first in the private health sector, because that's easier. We're only dealing with 16% of people and a small number of people on medical schemes. So it sounds flippant, but it is. And then you extend it to try and get coverage in the public health sector. The public health system, despite the allocation for funding, cannot afford Trikafta for cystic fibrosis. You're looking at 400,000 Rand per patient per year, right? but we can push medical schemes to do that. So the concern is under NHI, what will happen to treatment for rare diseases? Are people going to have to take up the stop up insurance to get it? That's seemingly what's going to happen. Or you will die because you won't get it. And again, I'm not being flippant. I've lost colleagues, I've lost friends. If we had dealt with AIDS denialism, if we had issued compulsory licenses, if we had dealt with the AIDS crisis early on, which our government didn't, then, you know, 3 to 400,000 people in our country wouldn't have died from HIV/AIDS when there was a drug. And so our concern is that is the pattern that's going to be repeated with rare diseases, because everybody will be so concerned about the funding model and the committees and the transparency, which is all great. But none of those legal cases that I've read, the legal papers, even talk about how you're going to protect the patient. What's in the benefit of services? Will it at least match what people are currently getting under prescribed minimum benefits for medical schemes or the current services in the public sector? And I guarantee you there's going to be exclusions, and they're going to cut services, or they're not going to provide services and treatment and life-saving drugs, which means we will all have to fight for each of those diseases. And again, if you can't get it under NHI, and you don't belong to a top-up insurance plan or a medical scheme because you don't have a job, I do not know where you're going to get this. You're going to have to go to a GP, but they're going to charge you, presumably, a price that is comparable to the private sector. That would mean you need more churches and NGOs to be set up to provide the rare disease treatment. The whole thing is self-defeating, because the reason why you set up an NHI was to have an equalized health system. So it almost feels like we're back in 1994. We're having the conversations of 1994 in a global system of 2025. So I don't want to sound alarmist to people with rare diseases, but I think we have to entrench as many benefits as we can now, so that you get to the point when NHI is implemented that that service cannot be taken away, which is why we're waging the battle on cystic fibrosis and many other diseases right now. And at the heart of that, why can't you get the treatment? Why can't you get it affordably? Why can't somebody give you a reduced price? Pharmaceutical corporations. Your next report.
Thanks, Fatima. Our next report, guys. Thank you. I know we are slightly over time, but we are coming towards the end of our evening. And so thank you for all your interventions. If you do have further questions, we do have to cut the Q&A right now, but please come chat to us, chat to each other. And we want to really keep this conversation going. I'm just going to ask the panelists to close. Yeah, please support our work. Download the report. You know, we are really enjoying what we're doing right now, and it's really impactful. And so, yeah, support Open Secrets, guys. Yeah, so panelists, closing remarks, 1 minute, please. Luthando.
You also, Luvano, for holding this conversation for us. There's so much of this to traverse, and yeah, it's not easy. So thank you for that. I guess my last thoughts are that we need serious intervention in this area. It is a life and death situation. So many of us are at risk, and unfortunately, that is being taken advantage of by a very powerful few. And I mean, maybe as a lawyer, I really think that we need to seriously consider how we view positive obligations on the private sector within the context of any kind of welfare services that they provide, not just health, right? There are so many different ways in which the private sector plays a role in how our lives look. So yeah, that's my final remarks. Thank you.
Thanks. I thought we already. Thanks, Luvano, and thanks for uh, being our project lead, and for hosting our conversation. And thanks to my fellow panelists as well. I think, oh, whether or not we like it, yeah, this is an issue of life and death. Um, and so, even if we're having difficult conversations and we're not where we need to be or want to be, um, those are the conversations I think that we should be putting our minds to, and the work that we should be doing. Because regardless of our debates and differences of opinions, at least we are at the place where we're having those important conversations. And if anything, the realization of the constitutional right to healthcare is fundamental, and the equal access to it is fundamental. And so if we are challenging and we're having difficult conversations and we feel like the fight is uphill, let's continue to do it, because it is, like we've said, an issue of life and death. And if we don't fight for this and work at it, then it's going to cost and continue to cost lives.
Thanks. I mean, my final comment is that all of us have a duty to hold power to account, whether it's public or private power. So we've got to hold those who wear fancy suits to account too. And we have the tools, we have the laws, we have the know-how, we have the modus. We can hold private power to account, and more of us need to do that, because fortunately for us, actually, we have a system that exists. The infrastructure is still there. We have a system that we can defend and advance. Unlike, for example, the situation in Palestine and Gaza, where the entire health system and health workforce is being decimated and being destroyed. So let's do what we need to do to save our healthcare system in South Africa. And there's many ways in which you can do that.
Thank you so much to the panelists. Thank you to everyone for joining us this evening. And I hope you enjoyed the report. Thank you to the Homecoming Center for having us. Thank you to the AV and to everyone who made this happen. We appreciate you guys, and have some snacks.